So let's move to the opening slide just to remind us what we're doing today, engaging participants in a self-change process. We've been emphasizing through the webinar so far the importance of trying to help people really change in their function, especially in relationship to the behaviors and the thinking and the attitudes that have to do with public safety and reoffending. And so we want to spend a bit more time today focusing on what is the self-change process and what do treatment providers do when they're doing treatment with somebody to help them to actually make functional changes, and then to make sure those of you who are on the court team side can really understand what to expect from treatment providers in terms of what changes people should be making and how change actually happens. Just a reminder, though, about some of the upcoming webinars so that you can perhaps plan those in on your schedule. Besides the challenging case one that Monica just referred to, that's happening on Tuesday, April 19 at 1 p.m. Eastern. The day before that, on Monday, April 18, we're going to have a session on relapse, continued use, or continued problem potential. What are the issues about assessing somebody who is either starting to use again, relapsing, and even mental health continued problems? And what causes those sorts of things to flare up? What would be some of the treatment responses to that? How sanctions and incentives fit into that, and what to expect when somebody has a flare-up and how to deal with it. So that's on Monday, April 18 at 1 to 2:30 Eastern. We're going to combine the question and answer session in that one on Monday, April 18. Then there'll be the challenging case one on April 19. And then Wednesday, April 27 from 11 to 12:30 Eastern, we're going to have a session on how do we get there from here. We've talked about a lot of different things that impact the policies and procedures and systems and treatment that you do, and we'll talk more about how do we sort of get to that place together as a treatment team and as a court team working together to reach the sort of new directions we're talking about. And then on Tuesday, May 3, from 2 to 3 Eastern Time, we'll have another challenging cases session. So we'll give you the heads up about that. But for today, we're going to focus on engaging participants in a self-change process. We have the rest of the hour to do that, and then we'll follow up with a question and answer session that I hope you'll be able to attend. You'll need to re-register for that as well. So let's get started, and really looking at what often comes up is that as we try to get people to be active participants in their own self-change process, it really requires us to move from thinking of people as having pathology that needs to be broken down and denial that needs to be broken and cracked, and you know, we often use these terms, breaking through denial and confronting resistance and making people see the errors of their thinking and so forth. So we think of the change process as there's pathology in the client, and then somehow we have to get through that shell of resistance and get them to change and see the error of their ways. Well, what I'm introducing to you really is the concept to start thinking less about pathology that we have to break through and sort of gain insight into, and to really harness a self-change process. And I'll explain more about why we're saying that. But a helpful way to start with people is to not think so much about pathology, and not so much thinking about resistance, but really to see resistance as an interactive process, which is as much a phenomenon that you create if you're treating a person or if you're a court team member and you confront their so-called resistance. You have as much contribution to that resistance increasing as it is a client or patient problem where they just have the resistance. In other words, resistance is often a problem with our knowledge and skills and attitudes, and often with the lack of availability of services, access, waiting lists, things that make it hard for a person to get into treatment that we often see as resistance, where it's often logistical problems, it's often our own skill difficulties in engaging them in a self-change process. So in motivational interviewing, and I'm referencing here the 3rd edition, so if any of you have seen that, it came out in 2013, and on page 412, they actually say resistance is a term previously used in motivational interviewing, now deconstructed into its components of sustained talk and discord. So you might say, well, how can we get rid of the word resistance? It's so applicable to all of our clients. You have offenders who are resistant to really change their friends, resistant to seeing that they have a problem with addiction, resistant to really becoming more pro-social in their activities and in their leisure activities. It's obvious that resistance exists. Well, I'm going to invite you to delete resistance from your vocabulary when it comes to helping people to change. In previous editions of motivational interviewing, if any of you have had training in that, you may remember we talked about things like rolling with resistance in motivational interviewing or responding to resistance. The trouble is with having the concept of resistance is that when you think of people as being resistant, and I'm suggesting you delete resistance, when you think of people being resistant, that's not a compliment. If you say to somebody, you're so resistant, it's not like they say, well, thanks very much for the compliment. I mean, that's usually a negative interaction. It's something that you're saying is a problem with them. They're a problem client because they're resistant. Well, what motivational interviewing in the 2013 edition is talking about is encourage us to even forget about resistance and to replace resistance with a focus on sustained talk and discord. Well, what do we mean by sustained talk? Well, sustained talk is whenever you hear a person talking and they're clearly saying things that they're not interested in changing anything. They're basically saying, I'm okay with keeping things the way they are. The status quo is fine. I want to sustain what I already have gotten or where I already am. There's nothing inherently pathological in a person not being interested in changing. They're not being oppositional. They're not being a problem. They're not being resistant. They're just basically saying that is not something I'm interested in. And we don't have time to go fully into all of motivational interviewing, but if you've had any training in it, or I'd encourage you to get training in it, they talk about change talk and sustained talk. So change talk is when somebody is moving in a direction of change. It doesn't mean they're having to say, my life's totally unmanageable, I'll do whatever it takes. But as I have on the slide here, they may be saying something like, well, maybe I have a drug problem and should do something about it if I don't want to get arrested again. Just saying maybe I want to change, maybe I have a problem is in the direction of change talk. Sustained talk is in the opposite direction, but it really isn't as bad as they say. They're just overreacting. It's not something I really think is much of a problem, need to do anything about. That's sustained talk. So when we're listening to people talk, instead of listening for resistance and denial and oppositional thinking and help rejecting, replace those words with just sustained talk or change talk. Am I hearing change talk, moving in a direction of possible change, or am I hearing sustained talk, where basically they're saying, this is not something I'm interested in changing. Now, if you keep beating on somebody who's saying sustained talk and say, well, of course you have a problem. I mean, you've been arrested, you had a drug-related arrest, you've had assault and battery, you've had burglary, trying to get money for drugs. You're in denial. You just have no idea about how far your addiction's taking you. You're so resistant to seeing what your problems have caused you. If you do that to somebody who's basically saying, I don't think it's a problem, they're overreacting, you're going to create discord, because you're going to be telling them that what they're thinking is not correct. And you know from your own experience and your own behavior, but certainly with clients, that they don't suddenly say, oh, well, I didn't realize I was thinking the wrong way. Thanks for pointing that out. Now I'll change. That's not what happens. Usually there's a pushback, and people start saying, yeah, but, or it's not as bad as I say, or it wasn't even my stuff, or I was in the wrong place at the wrong time, or they're profiling me, or they just on my case. They're going to do that, and if you keep beating on that, you'll create discord. So discord is about you, and more precisely about your relationship with the client. And whenever you notice discord, that says that there's something wrong with the alliance. Something has gone wrong in terms of engaging that person. So in a therapeutic alliance, we're trying to get on the same page. Are you more interested in abstinence and recovery than they are? Are you more interested in getting them to go to AA or take medication or change their friends than they are? If you are, and you keep pushing that point, you're going to create discord and actually move them in the opposite direction of change, and then you'll call them resistant. So I want to remind you about Prochaska and DiClemente and the trans-theoretical model of change, and we'll quickly review that a little later on, to say that what is important in the trans-theoretical model is that that was developed with the process of watching people who change on their own. Initially, this was with smoking, and they sort of looked at how do people who are smokers become non-smokers in a natural self-change way, even without a lot of treatment. And they realized people go through certain stages that we'll go over a little later. Many of you know about stages of change in the trans-theoretical model. But I want to emphasize one part here from Carlo DiClemente, who was one of the co-developers with Jim Prochaska, that what Dr. DiClemente is saying is that treatment is an adjunct to self-change rather than the other way around. We often send people to treatment and think, okay, treatment's going to make this person you know, into a brand new person where they're going to really gain insight, cut through resistance and denial, and embrace recovery. Well, when you think of treatment as the main thing that's making that happen, you really have it round the wrong way. What Carlo DiClemente is saying, treatment is an adjunct to self-change rather than the other way around. So he's saying the perspective that takes natural change seriously shifts the focus from an overemphasis on interventions and treatment and actually gives increased emphasis to the person, to the participant, to the person who's got the addiction, his or her developmental status, his and her values and experiences, and the nature of the addiction and the connection with associated problems, like in all of the 6 ASAM dimensions, and his or her stage of change. The point being that what we're really looking at is how do we focus on the person and engage them in a self-change process, because that's how you get sustainable change, not just when you have a big enough stick to beat them to submission in a mandated treatment program that is then going to do the treatment sort of to them instead of using treatment to facilitate a self-change process. I want to remind you, put this in some context of, this is a slide from Dr. Scott Miller, and if you want to know more about Dr. Miller, go to www.scottdmiller.com or the International Center for Excellence, Clinical Excellence. But if you Google Scott D. Miller or feedback-informed treatment or go to his website, you can learn more about what I'm just going to give you a very quick overview of. And that is that from 4 decades of research in treatment and psychotherapy, we know what the proportion really is. I mean, don't get too fixed on these exact numbers. This is to give you the proportion of how change happens and what and how treatment works. Because treatment absolutely works. People who get treatment do better than people who don't get treatment. But the contribution of what treatment does to a self-change process is really that sliver of about 13%. And most change happens in things that we don't really have control over, that we don't know quite what is happening in extra therapeutic and client factors, meaning that what we're harnessing is a self-change process, and where the change really happens is in the self-change process, in the context of where are they living, who are their friends, what are their leisure activities, what is their temperament, are they a risk taker or a thrill seeker, are they somebody who has friends who drink and drug, or do they have any friends who don't use, what is their culture and their values. All of these are extra therapeutic. They're outside of what you have control over in the treatment setting. You don't have control over the person's temperament. You can't make them into a different person. What you can though do in treatment though is facilitate a self-change process and harness that person's strengths and skills and resources in treatment. And even a big chunk of what happens in treatment that contributes to good outcomes is due to the alliance, the therapeutic alliance. You can see that about 60% of what happens in treatment depends on the quality of your therapeutic alliance, and we're going to go over that in a second. But what that basically means are we on the same page in terms of goals and in terms of treatment, and do we have a working, trusting relationship? So the therapeutic alliance is a big part of the outcome. Another big part of the outcome is the allegiance factors. Now, by allegiance, we mean no matter what model you're using, what evidence-based practice you're using, to what degree you believe in that and have allegiance to it and have hope that this is going to work and have a sense of passion about it, that conveys a sense of hope to the person. That's a big factor that makes a change too, because hope and a sense of positive results contributes to actually a person getting something out of treatment. If you were to present a treatment model but you didn't really sort of believe it and you're just going through the motions like a bad tour guide who's just sort of sprouting things out of a script, you're not going to inspire people in a change process. So allegiance factors and hope is an important part. And then techniques and models, evidence-based practices, contributes to the outcome too. You want to have your best toolkit full of things that we know works, evidence-based practices, but you don't want to get locked into one evidence-based practice as if it fits for all people, because we know that not all models fit all people, and you have to be ready to change tracks and change models if a person's not getting better. That's why you have to be careful of locking into one evidence-based practice as if that's going to work for all people. So in other words, treatment is important if you're using the therapeutic alliance to help a person in a self-change process, if you're providing hope and passion about what you're doing, and if you're ready to use whatever evidence-based models will engage that person, and if something's not working, don't get locked into it, but to switch and to make sure that you're ready to be flexible around what's going to work for this particular person. It isn't like you're trying to get them to join some religion. But you'll notice that the major part is beyond your control, extra therapeutic factors, temperament, values, things that you have. So that's why it's so important for us to harness a self-change process and not just lock people into, you have to be compliant with our program. And this is important both from a clinical treatment end, but for the court team to understand that as well. Just a reminder, if there's anything that's not making sense to you, please, let Monica know that you have a question or a comment or a disagreement, and we can interrupt me at any time to do that. Now, we talked about this in previous webinars, but I just want to remind you that the goal of treatment is not to have people to comply with a program, but to adhere to an individualized treatment plan that is worked out in the therapeutic alliance. In other words, the treatment plan is just the written expression of the therapeutic alliance, and the therapeutic alliance, as a reminder, is agreement on goals and agreement on methods within the context of a trusting relationship. We'll We'll go over that again in a little bit. And that criminal justice is focused on compliance to rules and regulations, and that's the correct mission for criminal justice, but that's not the correct mission when we're trying to engage people in a self-change process. And a reminder then that when people come in to drug court or problem-solving court, specialty courts, mental health court, that they are at different stages of change for different things. So I want to just quickly remind us about stages of change and to recognize that not everybody is at an action stage of change. Now, in stages of change, there are different models. You could use a 12-step model. Is this person surrendered or are they just complying? So the difference you can tell there is if somebody's just saying, well, how long do I have to be here and what do I have to do to jump through the hoops? What do I have to do to comply? Versus being there with some pain and some affect, surrender. Whoa, my life's out of control. How could I do this to my freedom, to my family, to my finances, to my values? So are they showing some sense of affective surrender, or are they just jumping through the hoops in compliance? Are they accepting or admitting? Admitting might be, well, yeah, I shouldn't have punched her, but I told her to get out of my way when I get that way. So sort of putting the blame on the victim. Or admitting, okay, maybe I used too much and get into trouble, but it's not as bad as they say, versus acceptance, which is, again, with some pain and with some affect. Whoa, how could I do that to her? How could I do that to my family? Are they identifying or comparing? When you hear somebody saying things like, well, I'm not as bad as them, or I never killed anybody, or I never lost my job, or I never did time anywhere as bad as that person. That's comparing versus identifying. I never killed anybody, but I drove drunk hundreds of times and I could have easily killed somebody. I didn't do as much time as that person, but I did time, and my freedom was taken away. I never lost my job, but plenty of times I was so depressed and just sat there, wasn't very productive. So we're listening for where's the person really at so that they can begin to actually see themselves in a change process, or are we going to have to do a lot of motivational interviewing, a lot of stages of change work to engage that person in a self-change process, which is really what we're trying to do. We're trying to engage that person in a process that's going to continue beyond some program. Now, many of you are familiar with Prochaska and Clementi's trans-theoretical model of pre-contemplation, contemplation, preparation, action, maintenance. I'll go over those stages in a second. And then Miller and Rolnick, readiness to change, not ready to change, unsure about changing, ready to change, trying to change, or doing what works. Now, this spiral of change is from a book called Changing for Good by Prochaska, Clementi, and Norcross. It's been around for, 20 years probably. But this is a nice diagram to remind us that it's a sort of a process of spiral of 1 step forward, 2 steps back, 3 steps forward, 5 steps back. It's never a straight line through the process of change where people are moving from pre-contemplation, I don't have a problem, this is sustained talk, I don't really need to change, this is not something I'm interested in changing. That's what pre-contemplation is, I don't have a problem. Or if they do think they have a problem, they're more than 6 months away from actually doing anything about it. So for all intents and purposes, they're not in the change cycle. Contemplation is the stage of ambivalence. Maybe I have a problem, maybe I don't. Maybe this is causing me more of a problem than I thought. On the other hand, it's not as bad as they say. So they're ambivalent, and that's not uncommon. In fact, that's most common for people who enter into treatment. If everybody was totally ambivalent, ready to do whatever it takes, they wouldn't need much treatment. They would have changed. Preparation is I've got a problem and I'm going to do something about it, and they mean in the next few days and weeks that they're going to take some action. If somebody says, okay, I'm going to quit using drugs on my next birthday, and they just had their birthday yesterday, that's not preparation, that's contemplation. or might even be pre-contemplation. They're not even interested in making a real change anytime soon. But preparation is, no, this is serious and I'm going to do, look at what it really takes to change. Action is, I'm already making changes. I've gotten rid of that friend. I've stopped using. I'm going to meetings. I'm actually taking a look at how I'm going to have to change my leisure activities, whatever it takes to really make a change. That's action. Now, once they've made some changes for 6 months or more, that's maintenance. They have to be focused more on relapse prevention, making sure they don't slip back. And then they might be able to terminate. Some people can terminate even from the tough addiction of smoking nicotine. That you have some people who are able to quit cigarettes for 20, 30, 40, 50 years and not go back. Other people always have to stay in maintenance because they're so shaky, they know that they're one whiff of a cigarette away from grabbing somebody's cigarette and smoking. So they might need to stay in maintenance indefinitely. So these stages of change are important in terms of what are we going to do in treatment, because if you have somebody who is at action for change or preparation for change, then by all means you develop a recovery relapse prevention plan. A recovery plan because they don't want to get into trouble again, they don't want to get into domestic violence, they don't want to be arrested again, they want their life to be better, they're interested in recovery. And so you work with them in treatment on a recovery relapse prevention plan. How do we make sure this doesn't ever flare up again as much as we can in a relapse prevention plan? And actually, you really are working on relapse prevention when they've actually achieved some sobriety and some success. That's in the maintenance phase. But if somebody's at pre-contemplation or contemplation, you don't develop a recovery relapse prevention plan. If you've ever heard me talk about this before, you really need to help develop a discovery dropout prevention plan. How do we help them to discover a connection between their drinking and drugging or their violent behavior or their hallucinations? How do we help them to see the connection and discover a connection between what they're doing and the trouble that they're getting into? The problems that they're having with relationships, with the law, with reoffending, with being locked up, with losing their housing, with losing connection with family and friends who are cutting them off. Many people who are in pre-contemplation, contemplation don't see that connection, even though it is so obvious to other people. Or if they see the connection, they're ambivalent about really wanting to do something about it. Okay, I can see that there's a problem, but I don't know if I really want to do that. So if somebody's in pre-contemplation and contemplation, you don't develop a recovery relapse prevention plan, you develop a discovery dropout prevention plan. Now, what do I mean by that? Well, you're trying to keep them coming back. You're trying to keep them engaged in treatment with a dropout prevention plan, and you're trying to help them to discover in a self-change process way the link between the problems that they have and what they are doing. Now, you can help them to discover that just by telling them. So it's always important to tell people, you have the disease of addiction. And I think that you're reoffending, and the court thinks that you're reoffending because you have the illness of addiction or mental health or co-occurring disorders. And the court's gracious enough to give you a chance at treatment because they think that if you can get into treatment and recovery, then the public will be safer and you won't reoffend and we won't need to put you in expensive prisons. So that's why you've agreed to do the treatment, to take a look at your behavior so that you can get what you want, to get off probation or not get locked up or get your kids back or whatever it is. But we can tell people that, and if they immediately see the connection and say, oh, I need to embrace recovery, I'll change my whole life and my friends and drinking and drugging and impulse control and anger, and help me and I'll do whatever it takes, good. Well, then you've moved them from preparation to action all in a few minutes of telling you what the problem is. But if you tell them that problem and they say, yeah, but, or have ambivalence, then they still need treatment, but they don't need recovery relapse prevention treatment. They need discovery dropout prevention treatment, motivational enhancement. If they think that they can hang out with friends and not use, and you explain to them how that's very dangerous and they're very likely to use again, you don't want them to be looking at that just from the case of a court mandate, but you want them to discover in treatment that I guess I really can't hang out with Joey and Billy because I ended up getting a positive drug screen because I have very poor peer refusal skills and I get overwhelmed if I hang out with them. You want them to discover that for themselves so that they then will take some action to get away from those friends. Now, you can tell them that, don't hang out with those people you'll likely use, but you want to let them be free to disagree with you. If they say, oh, I think I could, it shouldn't be a problem. And then if you just say, no, you have to do it, the court mandated it, well, they'll say they'll comply just to say whatever they need to say, but then they won't try very hard to actually do anything about it. And we want them to do a self-change process. If they think that they can recover without AA, and you explain to them why AA or other self-help mutual help groups like Smart Recovery or other communities of faith, why it's important to have those support groups, and they still don't get it, then that's what you're going to have to focus on in treatment as part of the treatment plan. How do we help them discover that they need other people? And the way that they're going to discover that is to do a discovery dropout prevention plan, like, well, let's try the no AA treatment plan, and now let's see what you're going to do if you get a craving to use, and who you're going to reach out to when the going gets tough. You want them to discover those things while they're in treatment, not just have that person sit through treatment, pretend that they're doing something, and then basically have it all blow up. So stages of change is important because it impacts the kind of treatment plan that you're going to do. Now, the first thing to do, though, is to engage them in a therapeutic alliance. What is it that the person wants? Why now do they want that? Do they know how to get that? And when are they willing to do it? So putting that all together in a way that sort of focuses first, in that first column, on what does the client want, who are they, what is the real thing that they want. Not, I don't want to hear what you think I want to hear. I don't want you to say what you think other people have just said if you don't really believe that. You know, thank you for being here. What is it that you want? Well, they made me come. Well, what do you mean they made me come? Well, I have to be here, or else what? Well, I won't get out of drug court, or I won't get off probation, or I'll do more time, or I won't get my kids back, or I won't get housing. Would that be all right if that happened to you? Well, no, that's why I'm here. Well, then thank you for choosing to work with me so I can help you get your children back, so I can help you not do more time, so I can help you get off probation. But why is it important to get your children back anyway? I mean, do you really want to have to take care of them? You can't go out whenever you want to go out. You know, you want to see, are they really intent on getting what they say they want? Well, I definitely don't want to do more time. I'm sick of it. I want to be roaming free and do what I want to do, go where I want to go. Great. Well, then do you know how to do that? Well, I just have to be here. Well, no, they sent you here because they think you have an addiction problem or mental health problem, which is causing you to offend. And so this is about treatment for that. So this is not about just sitting yourself in a program. Where and when are you willing to do this? Well, I'm here. Can we just get it over as soon as possible? Well, no, actually, this is about, do you even think you have a problem? And do you want to change that? And that you're in treatment here to sort of explore that. But I want you to be honest about that, because if you really don't think you have a problem, we're going to have to work on discovering whether you do have a problem. And then the assessment and the treatment plan is done in the service of really trying to help that person to make the changes that they need. And that's where we've talked before about assessing them in the ASAM 6 dimensions, finding out what the problems and priorities are, and then collaborating on a treatment plan, because that's what you're going to hold them accountable to in the process of a self-change process. Now, in motivation interviewing, there are 4 processes that are actually helping you to structure the way that you engage them in a self-change process. And the first process is engagement, which is basically what we just did in terms of developing the treatment contract. Why are you here? Thank you for being here. And you remember that we talked about 3 aspects of the Therapeutic Alliance: agreement on goals, agreement on methods in the context of a working, trusting relationship. So it really is, if you're working on abstinence, sobriety, and impulse control, and their goal is getting their kids back or staying out of prison, you're not on the same page. And B, if you're working on taking medication and they hate medication, or you're telling them to go to AA and they don't even like AA, you don't have agreement on the methods. And then C, if they don't feel they can be honest with you because they're just trying to say whatever you think they think you want to hear, then you don't have a trusting, empathic working relationship, which is the 3rd aspect. So engagement then is an important aspect which happens at the beginning, but it actually might mean you have to re-engage the person if you notice that they are not doing well, or if they initially were interested but now they are just sort of sitting there passively, not very actively involved. The other phases and processes in motivation interviewing are focusing, evoking, and planning. Now, by focusing, what we're talking about is once you have a person and say, what do you want and why do you want that, you are helping them to really think through, is this really important to me? I say I want my children back, but am I ready to do whatever it takes? Am I ready to get rid of Vinny the drug dealer? Or am I really ready to take a job and develop a good income that will show that I'm a good parent? Or if I really want to get a probation, am I really willing to make the changes in my life that will demonstrate that I am safe in terms of the public and in terms of reoffending? So what you're doing in focusing is working through that assessment about what is that you want, why do you want that, and then in evoking from them, helping the person voice the arguments for change. So you can keep using if you want to. What will happen if you keep using? Well, I might get arrested again. Well, what's the problem with that? Well, I actually don't want to do any more time. Well, then how can you not get arrested? Well, I don't know. I just think they have it in for me. Well, let's see how you were arrested and what you were doing. Who were you hanging out with? Who were your friends? What sort of activities were you involved in? Were you working at a job or were you drug dealing? So you're evoking from them in the assessment, looking at all of the aspects, trying to help them to begin to make a connection between what they would have to change if they're really going to get what they want. And then the planning is moving from evoking to planning. Now, when you're planning the treatment, it's important not to get ahead of where the client's at. It might be obvious to you they need to change their friends, stop using, go to self-help recovery groups, they need to start getting a job, they need to start getting rid of any criminal behavior, change their thinking. You can't just put that into a mandated treatment plan and expect that to become their self-change process, because it's really not their plan. So if you have somebody who's at an ambivalent stage of change about giving up some friends or about going to AA meetings, or even if they're ambivalent about whether they even have a problem, what you're going to have to evoke from them is, well, how will you prove that you don't have a problem? How will you prove that those friends are not a danger to you in terms of reoffending? How will you prove that you can still do well even though you don't want to go to AA or some other self-help, mutual help group? That's where evoking and planning comes in to develop an individualized treatment plan that is really focused on giving them the chance to do the research, as it were, in terms of the change process, and to make sure that they are understanding that this is their treatment and this is their treatment plan, and they're the ones who have to develop the kinds of plans that they will actually do, and then we'll see if it works. Let me pause here and really invite anybody who may have questions. I've thrown a lot of stuff at you before I go on. And is there anything that doesn't make sense, anything that you would like to apply maybe even to a client that you have? And this is what they said, how would this fit in with what we're doing in terms of engaging them in a self-change process? Monica, there's no questions yet?
No, it looks like at this time we don't have any questions.
All right. Again, I encourage you that if any of this doesn't quite fit with what you see or what makes sense to you, we want your participation, because that's the way you really learn to apply this stuff. It's not just all a theory. So if you do have any questions or comments or disagreements, please put those in chat to Monica and she can interrupt me. Now, I just want to tell you about some other evidence-based practices that I might have mentioned to you before in terms of interactive journaling. And just to let you know about conflicts of interest, there are some minor royalties I get from this, but that's not why I'm telling you about it. The power of interactive journaling is that this is an evidence-based practice that's on the Substance Abuse and Mental Health Services Administration's NREP list. NREP stands for the National Registry of Evidence-Based Practices and Programs. And interactive journaling is where people fill out in a journal, or what you might think of as a workbook, at a pace that makes sense to them. And this is just one of 200 different journals that have been developed for people in adult and children and adolescents, for people in criminal justice settings or addiction treatment or mental health treatment. This is the one that's about understanding the dimensions of change, the 6 dimensions in the ASAM criteria. And you can see in this example, somebody might be working on their family history and healthy practices, and they answer those questions and fill them out, and then they are identifying what they might want to talk about and review with their change team, with their treatment team. Another journal is called Moving Forward, the participant journal, that really is identifying how do we take what issues from the 6 dimensions. And I don't know if you can see it there, but in the top right-hand corner of the page on the right, you can see some little boxes, 1, 2, 3, 4, 5, and 6. That's referring to which assessment dimension in the ASAM criteria dimensions is a priority that this person wants to work on in their first program goal in their treatment plan. And you can see there about working out effective program goals. Is it something that's achievable? Is it realistic? Is it going to be, you know, manageable and appropriate for this particular person? And is it specific? And these sorts of guidelines can be important in terms of developing goals that make sense to people. So that's an example of 2 journals and a couple of the journal pages. There is a drug court journal that's designed especially for people in drug court, and you can learn more about these at changecompanies.net. This is a place where you can look at a few electronic pages of all the different journals and have a chance to, you know, see which journals might be most useful for you and your population. And better still, you can call somebody there and they can really individualize it to your particular needs. I see there's a question there. Do you have a template for a dropout prevention plan? So let me respond to that. remember, and let's go back here just to remind you why I even said that we talk about a discovery dropout prevention plan for people who are on pre-contemplation or contemplation. And so whenever we're thinking about, is there a template for a dropout prevention plan, what you're really looking at is what will help keep this person coming back. And so when you think about a particular person, you're saying a dropout prevention plan is not exactly the same as when you think of a relapse prevention plan. We often think of a relapse prevention plan where you can list what are your triggers, who are your friends who are negative, what are the activities that you want to stay away from. When you're thinking about a template, as it were, for a dropout prevention plan, you're looking at what's going to keep this person engaged. So, for example, you might have somebody who is wanting to get their kids back, and you want to help them to look at what will help you to really keep involved in treatment, even though you may have some ambivalence about whether you have poor parenting skills. Would that be putting a picture of your kids that you want to get back on your mirror to remind you that this is really important to hang in with treatment, even though the treatment may be getting tough? Is this a person who is trying to get housing and that they want to really have their own place? Would it be a part of your dropout prevention plan to have a picture or a listing of all of the features that you'd want to have in your apartment that you could eventually get if you actually made some changes in your life? I want my own place. I don't want to have a roommate. I want to have a place that's in an apartment complex with a pool. I want it to be close to these people. I want it to be close to this job. So you're really looking at what will keep that person engaged. Would it be helpful for you in a dropout prevention plan to look at all of the consequences if you reoffend, what's going to happen, and to remind you these are the things that I would give up if I get arrested again and have to be put away? So it isn't quite the same as a relapse prevention plan where we have some preset things that often are related to relapse. And in the session that we're going to do on April 18, we'll go into more depth about that. A dropout prevention plan is really what's going to keep this person hanging in for treatment. And that's tied very much to what, why, how, where, and when. Was it that you want? Why do you want that? So you're really trying to look at, for this person, really get clear on why you came here. And don't say the judge made me come, because the judge didn't make you come. If you didn't want to come and walk through the door and wait on a waiting list or whatever, you wouldn't be here. So it's not somebody made you come. What is it that you would lose if you didn't come? That's part of a dropout prevention plan, to really identify with the person what's most important to you, and then to help them to look at what are you willing to do with that. And if you don't do it, what will you lose? And that sometimes the losses of what will happen can be part of a dropout prevention plan. What's even better, though, are the incentives. What will you get if you hang in with treatment and make changes that will help you to get that? Now, if that didn't answer, please feel free to come back at me about the dropout prevention plan. And the discovery part of that is reminding you that we're really talking about motivational interviewing here. Discovery meaning you want to not have a treatment plan that acts as if the person is already interested in recovery. And if they're ambivalent about having a problem, you want the treatment plan to let them have that ambivalence and to talk in group about, I don't think I have a problem because, I was able to stop for 3 months. Or I don't think I have a problem because I only got arrested once and that person got arrested 5 times. You want them to be honest about that. And you want them to be honest about if they think that they can just stop without going to AA meetings. You want them to be honest if they didn't actually stop without going to meetings and they actually got a positive drug screen. You want them to be able to process that and not just violate them for that. All right, so let me just go on to tell you about some other resources for you. There is a Motivational Interviewing DVD series on the left there, the purple Motivational Interviewing, where Bill Miller and Steve Rolnick, who are the developers of Motivational Interviewing, are interviewed by Terry Moyers, explaining what's new in the 2013 edition. And then there's another disc in there that has a number of demonstrations about role plays with clients, about how to involve them in some of the changes that they're making in motivational interviewing. So it's a sort of a good demonstration. I see another question here. This is great so far. Thank you. I appreciate all discussion on this topic. I want to integrate discovery and dropout prevention in our addiction program. We use relapse prevention plan at present, but it would be great to have what you were discussing for individuals in early stages of change. Yes, so this is a comment basically saying, oh, that says privately, so maybe I just wasn't meant to share that, but I don't think I said anything out of order there, but just a great response to recognize that we need to expand out beyond relapse prevention and recovery plans to what we were talking about. On the right there is a 5-part series of DVDs on this is from a workshop that I did a few years ago on helping people change. And if you want to get that in more depth, and again, a conflict of interest, I do get royalties from that. So I just want you to know in terms of transparency. But again, don't let that hold you back from getting that if you think that would be helpful to you. Now, one of the things that I just wanted to emphasize about all of this is that these 4 processes of change, engagement, focusing, evoking, and planning, it looks like they sort of follow along in sequence. And to some extent they do. In other words, it would be hard to not start with engagement and go straight to planning. That would be a problem. That's really the problem we have sometimes in mandated treatment, that we mandate a particular level of care, length of stay, a level of abstinence, and a level of get rid of all those friends. In other words, we sort of mandate the treatment plan before the assessment's really been done and before we've identified what stage of change that person is at. So you shouldn't do the planning before engaging and evoking and focusing. But if a person is in treatment now and is now beginning to make some changes, but they slip back, say they get a positive drug screen, or say they get, they initially said that they would stay away from certain friends and now they're getting mixed feelings about it, or they are slacking off in terms of their participation in group or in terms of meetings. This means that you might have to go back to the engagement plan and say, wait a second, what are you here for? Are you really wanting to get your children back? Are you really wanting to do less time? Are you really wanting to not get arrested again? Are you really wanting to get a probation? Because what you seem to be doing is behavior in the opposite direction. You're hanging out with those friends again. You're missing meetings. And so you may have to go back to the engagement. It might be that they're still engaged and want that, but you have to start refocusing and evoking from them. You need to go back through the 6 dimensions and identify, did we miss something? Let's look again at dimension 3, emotional, behavioral, cognitive. Are you sure there wasn't any trauma? Have you really been working hard on your anger issues? Do we need to change the treatment plan? So these other processes of motivation interviewing can flow back and forth depending on the outcome. And that's what we mean about engaging people in the self-change process. If you see them not actually changing, that's not a message to say, well, then they need to be kicked out of treatment. That's a message to say we need to go back and see where we need to re-engage them or what we need to evoke from them and focus more on the assessment, how we might need to change the treatment plan. We have just a couple of minutes left, so I want to make sure that we're covering anybody's questions or not. And of course, would love you to have questions between now and tomorrow, where we really can use the time to apply this to your situation. So if you have questions not right now, please send them though between now and tomorrow, because we want to go more in depth with this, but make it applicable to what you are doing and how to apply this in your situation. Monica, do we have anything else from anybody?
It looks like we do not have any questions or comments at this time, no.
All right. What makes this useful, of course, is not to have a didactic session, but so if after you ponder this, you have some questions about how do I apply this to a situation I'm with the person right now that you're working with, please send us a little question or note or comment on that, and we can deal with that tomorrow in the follow-up question and answer session from 1 to 2. From 11. What is it?
It's at 1 o'clock Eastern.
1 o'clock, right? 1 to 2 tomorrow for the question and answer session.
It looks like we do have one question, Dr. Mee-Lee. This is from Mr. Ivan Nelson. He says, can the process of allowing clients to point out problem behavior further facilitate or promote discord in the therapeutic relationship if we confront clients?
No, the way, I mean, confronting, if you do heavy confrontation, but if you're, say, in the service of helping the person to get off probation, and one of the things you've identified with them in the assessment is hanging out with certain friends, and then they start hanging out with those friends again, it would be important to share that with them and say, I'm noticing you're hanging out with those friends, or I'm noticing that you're missing meetings, or whatever. This is moving in the opposite direction of what you're wanting to get. Have you changed your mind about that? So there's a way to share your concerns about what they're doing, not to create discord, but in the service of saying this is not helping you to get what you want, and you agreed in the treatment plan to be working on this. So anytime a person is not following their treatment plan, now this assumes that you're developing a treatment plan with them where they're going to be working on certain things. When they're not working on those things, that's not bad confrontation. That is really saying, is the treatment plan something you don't agree with anymore? Or you agree with it, but you're having trouble following through with it. So you do want to point that out to them in the service of tweaking the treatment plan or re-looking at helping them to make the actual changes. And if we, again, join us tomorrow, so if you can, we can go on further. Does it look like there's another person who wrote in?
It looks like Cherish Menard wrote in and just wanted to thank you for the webinar today, and says that the knowledge on the stages of change and self-talk is really helpful in her area of work. Oh, great. All right. I appreciate that. Well, we're out of time, and Ivan, I don't know if we answered everything, but if you're available tomorrow, we'd love to expand on this. And anybody else too. My passion is about having you be able to use this, not just have this be head knowledge. So I hope you can join us if you can tomorrow, same time for a follow-up session, and we'd love to have a more free-flowing application to your situations. Absolutely. Thank you, Dr. Mee-Lee. And if anyone does have any additional follow-up questions, please go ahead and just send that to justice@american.edu, and we'll be sure to address them in tomorrow's session. All right. Have a great afternoon. Thank you, everybody. Bye-bye.